Si metoclopramide, we can use the metoclopramide with yung sa first line of antiemetics natin. So, madalas before, ginagawa namin based doon sa 2007, si metoclopramide with dexamethasone or dexa with metoclopramide. But this time around, sa latest po, sa 2014, the 5-HT3As plus either metoclopramide or the dexamethasone. These are our 5-HT3. Ondansetron, Grani, Ramosetron, and then the Palonosetron. I think ang pinakamura si Ondansetron. Next si Grani, and then si Ramosetron, and then si Palonosetron. Tapos our corticosteroid still, the dexamethasone, yung muscarinic antagonist natin, si scopolamine, the dopamine antagonists are haloperidol, droperidol. So phenothiazines natin, and then high antihistamines, and the latest and the newest that we have is the neurokinin 1 antagonist or the aprepitant. We do have it here na po, 3,000 yung isang aprepitant. Tapos, next please. This is what we usually do. Recommended doses or dosages of the antiemetic drugs per prophylaxis in adult lang naman po. So, dexamethasone, sometimes we give kasi the 4 milligrams and 8 milligrams. For the anesthesiologist, please do mind if you are giving NSAIDs and at the same time, meron kayong round the clock na dexamethasone kasi baka nag-bleed ang wound ng patient tapos di ba, dexamethasone is also a pain reliever. Steroid, anti-inflammatory po siya. Tapos nagbigay tayo ng another NSAIDs, dalawa na po sila, the same actions, baka mag-bleed ang patient natin. We had one sa Davao, not my patient, neuro case, diba? Neurosurgeons and neuroanalysts are fond of giving dexamethasone tapos with Q6 na ketorolac. Tapos nag-bleed ang patient 24 hours post-op. No other pwedeng masabihan natin na it's because of this or nag-retch ang patient or ubo ang patient or but it's sa ketorolac and the dexamethasone. So please be careful. Watch out. Pag nag-induce kayo, nagbigay kayo ng dexa, pwede kong magbigay kung nag-ketorolac kayo, half of it na lang muna or you skip the first 8 hours na dose niya, saka nyo na ibigay. Kasi meron naman na kayong dexamethasone. So you give the first dose of NSAIDs 8 hours after. Then the second class, ito po yun, mga diphenhydramate, scopolamine, and the metoclopramide. Again, metoclopramide is not an antiemetics, but it will help with the forward flow po. Next, di ba madalas metoclopramide natin is just 10 milligrams. Dito po kasi this is based sa American standards, 25 to 50 milligrams. Baka po kasi pag nagbigay kayo ng metoclopramide sa patient, matanda, 80 years old or 70 plus, is biglang akinetic or biglang may EPS si patient. So, careful with giving metoclopramide also. So, kung hindi natin alam, after pagbigay ng nurses natin ng metoclopramide, kasi yun yung PRN natin, tapos biglang tumirik ang mata ni patient, or may jerking siya, that's because of the metoclopramide. So, please be careful. Tansyahin nyo din kung ano yung magiging PRN doses ng mga patients po natin. So, MK1 antagonist, this is the newest antiemetics. It competitively inhibits the binding of the substance T. So, aprepitant, this is the first approved for the CINV. What we do have is netupitant. It's aprepitant with palonosetron. Combined po, it's around 5,000 plus, 1 capsule. Pero it's good for 21 days. This is for the chemo-induced nausea and vomiting. And then, next is the palonosetron, the new generation of the 5-HT3As. So, for the Pag sa operation naman po, we do have the 75 microgram. We give it, as anesthesiologist, you can give it prior to induction. So please give it slowly. Kasi baka manigas ang patient, nagbigay kayo, or hindi, nagmamask kayo, nagpabigay kayo sa nurse or sa assist niyo po ng palonosetron. Pagbigay niya, mabilisan, wala pang 10 seconds, nabigay niya, sa chest rigidity ang patient. So, careful lang po. So, pag pinabigay niyo po si palonosetron, slow IV push, 1, 2, 3, until 10 seconds po. Tapos, the recommended dose is 75 micrograms every 3 days or every 72 hours po. These are the key features for our palonosetron extended half-life. So, more than 40 hours, but it will reach up to 72 hours. Next is yun. This is the comparison of the palono, ramo, ondan, and the gravisetron. So, ito po yung half-life ng patients. Ito po yung time na pwede tayong magbigay ng ibang round the clock. And yung round the clock kasi natin, tinitignan natin sa half-life ng mga gamot. Hindi tayo basta-basta nagbibigay lang ng mga gamot. Round the clock or yung PRN na gusto ko ganito, every 8 hours. We base it on the half-life of this medication. So, kung nag-ondan ka, Q4. Granny, most of the time, it's 9 hours. So, 9 or 8 hours or 6 hours. 6 to, basta nag-fall ka sa ganong range po. Si palonosetron, it's from the 40 hours, but or up to 72 hours. So, meron po kayong standby time or meron kayong kasi most of the time, these patients on the 40th hour, meron na silang nafe-feel. May nauseated na po ang patients, but they don't vomit naman. So that's why palonosetron plus dexamethasone or palono plus metoclopramide or palono, metoclopramide, tapos ang PRN natin is si haloperidol. Then, what else? So, this is the comparison po. Siyempre, bida po si palonosetron. Sa slide po na to. Next is, this is done by the, yung sa lab ng gynae surgery. Next please. Naghahang siya. Nasusukaan ay. If you do have questions po, you can ask naman po ngayon habang naghahang ang laptop ni Ma'am Sally. So, halimbawa, nagbigay po kayo ng palonosetron plus dexamethasone on induction. Di ba po, next niya would be Q72 hours. Pwede po magbigay kayo ng PRN doses, metoclopramide, either 10 milligrams or the 5 milligrams with dexamethasone or promethazine. So, tulog si patient. Next would be haloperidol. You can also give haloperidol sa patient. Tapos, with dexamethasone. You cannot give most of the time po kasi sa yung dexamethasone if the patient is diabetic din. So, baka lalong tumaas ang sugar. So, careful. That's why you need to pick your PRN doses and yung mga idadagdag niyo po sa mga gamot na ibibigay ninyo. Wala po siyang dekahon. It's always a case-to-case basis po. Walang ibang questions. Si tramadol, once you give tramadol, yun po, you can also give yung round the clock na Dexa, or if the patient is not able to buy naman palonosetron, pwede naman pong other medications. So, pwede kayong mag-combine ng either the second lines na lang ho, or you can give the ondansetron plus metoclopramide or ondansetron with dexamethasone. Tapos yung mga other medications niyo po na PRN could be haloperidol or promethazine. Depende po. If the patient has cardiac problem, please do or tignan nyo, especially kung sa sa anesthesia, pwede kayong magbigay ng mga gamot, ng mga antiemetics ninyo habang nakakabit siya sa cardiac monitor kasi baka pagbigay ninyo nagkaroon ng prolongation of the QT interval na patient. So, si palonosetron, siya ang least na pwedeng magkaroon ng side effects sa prolongation of the QT interval. What else? Yes, Bob.
Do we have a guidelines with regards to the use of palonosetron? What I mean is, if we only have one risk factor as compared to 3 or 4 risk factors, pwede bang observe na lang pag 1 na ang risk factor?
Yes, sir. Pwede po.
3 to 4
Yes, apo.
indicated.
If the risk factor is more than 2, meron na po kayong dalawang naka-standby ng mga medications or you can give kahit 1 dose tapos PRN. But if kung let's say isa lang naman, isang risk factor lang which is about 20% na magkaroon siya ng post of nausea and vomiting, pwede ho, if the patient is not able to buy mga cetrons, you can give yung second lines, sir. Or you can give also, para mag-combine na lang ho muna kayo. Para at least meron tayong peace of mind pag uwi sa bahay, or lalo na pag mga high-risk na surgeries. Pwede wait and see. But make sure kung wait and see, meron kayong standby orders around the PRN for the patients. Para, kasi pag, let's say, 12 noon, susuka si patient. Tapos kasi, wait and see lang naman tayo. But it took quite some time para ma-rounds ni resident, yung ganito. Tapos pag nag-round siya, matagal pa siya mag-text or tatawag sa inyo. Tapos matagal natin ma-address yung nausea ng patient natin. Baka naging later on, sir, mga few hours after, nag-vomit na si patient. So, we can give, sir, yung mga standby natin, PRN doses po. Yung mga second line, kung anong available sa ating hospital po, sa clinical setting. Basta meron po siyang standby. Pero if more than 2 na po ang risk factors, please do give, round the clock and at the same time, PRN doses. Or kahit na PRN doses lang, anyway, naka-standby lang naman siya. Pag nasuka si patient, you can give it right away. The problem with the PRN doses lang kasi, mahirap siya i-control pag nandyan na ang nausea and vomiting. So pag inunahan natin yung post of nausea and vomiting, it would be better. At yung mga studies lang po. So, this is the summary of the lecture for tonight. Summary na palagan. So, PONV is really a common clinical problem for us. The incidence and the impact of this are often underestimated. So, assessing the patient risk is always critical to our management to these patients to ensure appropriate antiemetic prophylaxis. And in patients who are at increased risk, please do a combined or multimodal approach for these patients, multimodal approach for the PONV and PDMV. So for the ambulatory patients, especially on the ambulatory patients, recognize the risk. 4 lang po yung risk factors. Babae, non-smoker ang babae, meron history of motion sickness, tapos gagamit ng opioid ang anesthesiologist post-op. So yun lang pong 4 na yun. And then, liberal use of the PONV prophylaxis, ambulatory surgery, narcotic-based anesthesia techniques. All of this can be adjusted naman eh. Pwede naman kausapin natin si anesthesiologist kung ano po yung best na pwedeng gawin natin for these patients para uwi sila happy at hindi sila, kasi kung ambulatory surgeries, pag uwi sa bahay, that's the post-discharge nausea and vomiting, saka sila nasusuka,